Welcome to SheTV.com, where board-certified physicians talk to you about women's health. In this episode, Dr. Margaret Hall, a board-certified OB-GYN, talks to us about robotic hysterectomy.
All right. Hello. I want to welcome you to SheTV and another session about women's health care. I am Dr. Dana Bogg. I am a board-certified anesthesiologist. I practice at Lakeside Women's Hospital in Oklahoma City, Oklahoma. I'm here today with my friend and colleague. This is Dr. Margaret Hall. She's a board-certified OB-GYN. She practices at Lakeside Women's Hospital also, and we've gotten to know each other and work with each other for, 15-ish years. 18? Okay. I got out there in '02, and you must have come just a few years later. Okay, all right. Well, we want to talk today about a robotic hysterectomy and what all is involved with that. But first, maybe we need to start off with what is a hysterectomy? What does that term itself involve?
So hysterectomy refers to removal of the uterus.
Okay.
Some women elect to have their ovaries removed at the same time. And so some women will call it a partial hysterectomy if they leave their ovaries, but hysterectomy, again, is removal of the uterus, usually along with the cervix at the same time.
Okay. All right. So tell me, or maybe there are probably several options for hysterectomy or for the uterus removal. What are those, or which ones are probably the easiest tolerated?
Well, so back when I was a resident and you were too, probably the most common way to remove a uterus was an abdominal procedure. So a bikini cut across the lower abdomen and usually involved 2 to 3 days hospital stay and a 6-week recovery time. Since then, we've tried to develop ways to remove the uterus as a minimally invasive technique to decrease the hospital stay for patients and increase their ability to get back to work, back to sooner. So
Okay.
so some hysterectomies can be done vaginally without incisions, but if a woman has a bigger uterus or a lot of scar tissue, say from C-sections or endometriosis, a vaginal hysterectomy is not always feasible. And so to avoid making that larger cut on the abdomen, a robotic procedure gives us the ability to get small instruments deep in the pelvis and remove the uterus without having to make that larger incision.
Okay. It's very cool. I get to do the anesthesia for those, and it's very cool to see a large uterus removed, and there are just 4 little poke holes on the abdomen. That part is cool.
Cool.
Yes. So go ahead and just explain that.
So it's done under a general anesthesia, which you do, so the patient won't feel or remember anything. And after we prep the abdomen, we do make 4 small Band-Aid incisions. They're just little 8-millimeter incisions, so usually 1 near the belly button, 2 on one side and 1 on the other side. We insert a camera through the belly button incision. We do have to put some gas in the abdomen to puff the skin up so we can see, and then insert our additional instruments. And then the robotic arms are attached to 3 of those.
Okay.
Then the surgeon moves over to the console. We put our head in there, and the surgeon herself or himself is moving the camera and 2 of the instruments. The 4th instrument's usually managed by the assistant. So the robot won't do anything without the surgeon there in the console. And the surgeon moves those instruments. They're wristed instruments, so it allows the surgeon to get those instruments deep into the pelvis to get to, say, the uterine artery to get around the cervix, to dissect off the bladder if there's scar tissue from C-sections, to take care of endometriosis.
Okay. And then how is the uterus actually removed?
So once the uterus is removed from its blood supply, we make a circular incision around where the cervix and the vagina meet. And at that point, the uterus is disconnected from everything. We remove it out the vagina and then change out our instruments for sewing instruments. And then we sew up the top of the vagina with this slowly dissolving suture. Then wash everything off. And then usually as an additional safety step, because we work so close to the bladder, we'll do what's called a cystoscopy, where we look inside the bladder while we're looking from above and just make sure everything is safe, no bleeding. And at that point, then we'll remove all the instruments from the patient's abdomen and sew them closed with dissolvable suture and surgical glue.
Okay. And it looks great. You really wonder, how did all of that get out? And just leave those small incisions.
So much better. So I have patients who go home who don't even require narcotic medication. So one just take Tylenol and Motrin. A lot of patients are back to work earlier than 2 weeks, especially if they have, say, a desk job or work from home. So it's not the 6-week recovery time that it used to be for a lot of women.
Excellent. And that allows them to get on with their life.
Right.
Instead of just being kind of in limbo for a while.
Yeah.
Okay. Are there complications? I guess common ones or not so common ones?
The main risks are bleeding, infection, damage to internal organs. So the blood loss from a robotic hysterectomy is usually pretty minimal, not anywhere near requiring transfusion or anything like that. We'll check a blood count before and after surgery just as to be safe. Infection is possible, but it's much less likely through these smaller Band-Aid incisions compared to an open incision. We will give the patient IV antibiotics before surgery, and there's some additional things that we do to prevent infection, such as washing with Hibiclens the night before and the morning of surgery. Damage to internal organs, the main organ we worry about is the bladder, just because it is so close to the uterus. And again, we do take those additional safety steps just to make absolutely sure that the bladder is intact after the surgery. So very unlikely to happen.
Okay. You said that most people spend the night.
Mm-hmm.
What if I don't want to spend the night?
I've had some patients who'll go home the same day, especially if the surgery's done earlier in the day. So they have to meet certain criteria, be able to go to the bathroom on their own or urinate on their own, and their pain and nausea need to be controlled. But it's certainly an option.
Okay.
Yeah.
Okay. I would say that I think some patients don't want to stay hospital comfortable. Yeah, more comfortable at home. Yes. And I will add to what you have said, Dr. Hall, about the pain control. When we first started doing robotic hysterectomies at Lakeside, which has been many years ago, I just couldn't fathom that someone could have a hysterectomy and maybe only require a pain medicine intra-op and maybe one dose post-op and then be on a pill and go home and feel fine. And it's true.
It is true.
It really happens. It is not that uncomfortable.
Right.
Yeah.
So, no, it's really nice that we have this option for women.
So I agree. Is there anything else that we haven't talked about that you want to mention? Any other? I think we got complications. That sort of thing.
Right. So we usually see patients back 2 weeks and 6 weeks post-op just to check incisions. We do need to look in the vagina at the final post-op visit just to check those vaginal sutures. We do ask 6 weeks of no sexual intercourse afterwards, just because those vaginal sutures need time to heal and rest. But day-to-day activities and working usually are most patients can get back to their lives so much quicker than they used to be able to.
Okay.
So again, it is very important to avoid sexual intercourse for at least 6 weeks after the procedure to give those vaginal sutures a chance to heal.
Okay.
We've unfortunately had a couple of patients who will decide to resume sexual activity sooner than that, and the top of the vagina is just a little bit weaker for a while after surgery, and so the risk is something called cuff dehiscence, where the vaginal edges become separated, and they do have to go back to the operating room for us to repair that.
Okay. So if they'll wait the 6 weeks,
6 weeks, sometimes a little bit longer, just depending on that final post-op exam and how those sutures are starting to dissolve.
Okay. Okay. And that's for their own safety.
Right. Yes.
No one wants to be almost healed from a hysterectomy and then have to go back to surgery and have another surgery. Because then I'm sure that also prolongs intercourse even further,
Right.
or I would assume that that it does.
So they can be romantic in other ways.
Okay. Okay. All right. And I wanted to agree with your point on blood loss. That is, again, one of those things that I've seen from the anesthesia side. When I was in residency and early private practice, and we were doing more of those abdominal hysterectomies, it was very common to lose 600, 700, 800 cc's of blood. I guess not exactly common, but it was more acceptable. And sometimes that's, to think about it, that might be like a unit of blood, making her maybe anemic after the surgery, especially if she was to begin with because of bleeding that led to her need for hysterectomy. But with the robotic hysterectomy, we truly see minor blood loss. Maybe 50 cc's, maybe 100 cc's at the most. And when we're done with that surgery, our surgeons, like Dr. Hall, will say, 100 cc's? And it's like, yeah, but that's a tiny amount. That's 2 shot glasses full. That's a very small amount. That's not anything that has to be replaced compared to an abdominal hysterectomy where we might see 6-8 times that amount.
And it shows up in their blood count the next day. I'm continually surprised. It's like, wow, they hardly dropped at all.
Right. And I would think, too, that helps their recovery be faster because we're not dropping that blood count down to where they're tired all the time until their body has had time to replace that blood loss on its own.
Yeah. Lots of advantages.
Oh, yes. Lots of advantages. I totally agree with you. Well, thank you so much for being with us today.
Thank you, Dean.
You bet. Bye-bye.
Bye.
Thank you for watching SheTV.com, where board-certified physicians talk to you about women's health.